CMT. We're here today to talk about the surprise billing and financial transparency legislation that was passed during the last COVID bill in December of last year. With me, we have Adam Buckalew, who will introduce himself a little later. But we really want to thank everybody for being on here and be able today to give more clarity to the Transparency and Surprise Billing Act that was passed. So from there, we'll go ahead and get started. So surprise billing legislation and transparency was passed in December of last year, and it's focused on two sides of a bill. Number one is patient protection and leaving patients harmless from out-of-network costs when they go to an in-network facility. So that is really all surrounding when I go to a hospital, making sure that everybody that provides services to me provides them on an in-network rate, and I'm not left holding bills for out-of-network providers. That's not what we're going to focus on today. We're going to focus on the second part of that, which is price transparency. And this is all about giving patients the ability to understand what their price is when they have scheduled visits to see physicians. And it's across all services and items in healthcare. So why is this bill in effect? The bill is really in effect because we've seen an increasing amount of out-of-network bills going to patients where they were unexpecting these bills. They went in for one procedure in network, but other people providing services were not in their network, and they've got bills that were piling up because of these medical procedures. And then, 40% of the U.S. population really struggles with bills over $400. And because of the price of healthcare in our country, many of these bills for the out-of-network services are much higher than the $400 that individuals typically do. So what we're doing is really trying to explain today how these bills are going to be reduced and how laboratories can help streamline the process for the patients and providers. From there, we're going to talk about the No Surprise Act and what the timeline is. So as I said, legislation was passed in December of 2020. The first interim final rule came out around the patient protection in July of this year. We expect the second part of that patient protection interim final rule to come out at any time. And then a notice of proposed rulemaking in the September-October timeframe, really around the transparency side of it. Statutory legislation effective date does go into effect in January, and the enforcement for the patient protection will go into enforcement. The transparency side has been taken down to some time in the future, which will be around the notice of proposed rulemaking. So they give enough time for people to really take their breath and get and understand what the laws are, and then how they're going to prepare to execute on those laws and make sure they have the products and services in place. I would like to introduce Adam Buckalew. Adam has spent a long time working on this legislation. He spent time on the congressional side working on the legislation, and then as it moved into the Senate side, he also spent time on the Senate side making sure and nurturing the bill so it could get passed in December, and now has kind of gone outside of the Senate to really help industry with the implementation of that bill. So there, I will pass it on to you, Adam.
Thanks so much. Really a privilege to be here today. As Andrew said, I had the unique opportunity of debating this legislation both in the House of Representatives when it was moving through the Energy and Commerce Committee initially, and then as well as in the Senate with the Health, Education, Labor, and Pensions Committee with then Chairman Lamar Alexander of Tennessee, who is now retired, as well as my boss, Greg Walden, who is now retired from the House of Representatives. So let's jump right in. I hope I can help provide some clarity today on this legislation. So really, this legislation sought to end the practice of balance billing, which is the practice where the patient is charged the remainder of what a provider charges and what an insurance company covers is their allowed amount. This legislation ends that practice of the facility or provider who is out of network having the option of sending the balance bill to the patient and holds the patient harmless to what their in-network cost-sharing agreement would be. To develop a scope around the parameters of this legislation, lawmakers and staff who negotiated this legislation had to come to some parameters of how far that protection would reach. So the scope of the balance billing protection is primarily in two settings. The first is emergency services, as well as those post-stabilization services in an emergency setting, delivered by an out-of-network provider or an out-of-network emergency room. And the second is non-emergency services delivered by out-of-network providers at an in-network facility or an in-network provider at an out-of-network facility. For the purposes of the law, the definition of facility is a hospital and an independent freestanding emergency department. And regulations have also extended that to urgent cares, as long as they are state licensed to provide emergency services. And the definition of a freestanding emergency department, these are primarily more prominent in Texas and Oklahoma, is a geographically separate and distinct and licensed separately from a hospital under applicable state law, and provides any of the emergency services. The next bullet there is the independent dispute resolution. This is commonly called arbitration. It's a wonky word that lawmakers used for resolving the dispute between payers and providers of what portion of that outstanding balance bill should be paid. So in other words, since the patient can no longer be on the hook for paying the remainder of the bill, there had to be some type of dispute resolution between the providers and payers to determine what amount of that bill would be paid. There's a lot of considerations that can go into the independent dispute resolution process, such as the median and network payment, the complexity of the case, the quality of the care, the teaching status and case mix of the facility. But the focus of today's conversation is primarily going to be on transparency, but I wanted you to have an awareness of level set of the patient protection side of it. There is one exception to the patient protection, and that exception is a notice and consent process. So patients may voluntarily or knowingly consent to out-of-network care. The joke that I always say is, I call this the Dr. James Andrews provision. So since Dr. James Andrew is the team doctor for the Washington football team, and he did a knee surgery on one of their running backs, I may be out on the national mall playing flag football or softball and hurt my knee and say, hey, I'm just as good of an athlete as a pro football player, so I want to knowingly and voluntarily consent to seeking out-of-network care by Dr. James Andrews. So I'm going to fly to Birmingham and have my knee done. This was intended to be an option for patients. It was never intended to be a loophole where out-of-network providers or facilities could circumvent the law. And so there was a process that was set forward so that the patient was well informed of the decision that they were making to consent to out-of-network care. That's some of the bullets that you're seeing here. So for instance, there has to be a written notice. Another thing that has to be provided is a good faith estimate of the amount that the patient may be charged. The notice has to say whether or not the payment will apply towards cost sharing or the deductible. If there's a medical management limitation, that information has to be provided to the patient in advance. The notice and consent does have several providers listed by name that there is no exception that they can utilize this process. So you see these listed here. This is emergency medicine, anesthesiology, pathology, radiology, diagnostic services. And what all of these providers have in common is typically these are not shoppable services. When you seek care from an anesthesiologist, you typically don't seek out an anesthesiologist to provide that care for you. To put it in kind of layman's terms, when you go to get a surgery, you may select the surgeon, but you may not select the assistant surgeon or the anesthesiologist or the pathologist that the sample was sent to after they remove something during the surgery. So since you cannot seek or typically you would not seek care from one of these specialists, there is not an exception for them to provide notice and consent for patients to voluntarily and knowingly seek out-of-network care. There's one exception, and that exception is for advanced diagnostic laboratory tests. And the reason is twofold. One, sometimes advanced diagnostic laboratory tests are shoppable services. You may seek out a certain laboratory that specializes in a certain therapy for cancer, for instance, or to get a validating or confirmatory or affirming diagnosis from your oncologist that sends you to an advanced diagnostic laboratory for a specific reason. And then you would schedule care. And since you are scheduling care, if it were 3 days in advance, arguably they should have the option to provide that notice and consent for a patient to voluntarily consent to the care. The secretary did not, in the first rulemaking, choose to provide an exception for advanced diagnostic laboratory, but they did ask for comment from stakeholders of if they should provide that and in what settings and which scenarios. The implementation date for the notice and consent to be specified by the secretary was July 1st. That was a deadline that was met. And the effective date of the notice and consent, as well as the patient protection, is January 1st, 2022. We will talk about timelines throughout this conversation, but we'll really wrap it up in a bow at the very end. So that brings us to price transparency. And the law includes 10 provisions that lawmakers and staff consider to be transparency provision. This ranges from maintenance of a price comparison tool to state all payer claims databases to mental health parity to prescription drug costs. But for the purposes of today's call, we're going to walk through 4 provisions. So we're going to jump right into it. The first is Section 107, and this is cost sharing on ID cards. There's an obligation that group health plans and individual health insurers provide cost sharing information on your plan ID, the type of plan ID that you would keep in your wallet. This should include the deductible, the out-of-pocket max, a phone number, and a website for consumer assistance. And this was really something that was pushed primarily by the Doctors Caucus in the House of Representatives and providers who think that the better informed patients are about their cost sharing obligations, the better informed decisions they'll make about the care that they seek. And so lawmakers set out a statutory effective date, statutory meaning the deadline that was put in the law of January 1st, 2022. The second, and we're going to do these next 2 slides out of order, is Section 112, and this is a good faith estimate. And this is for scheduled care for at least 3 business days in advance. The provider or facility must verify within a day what type of coverage the patient has. So if the patient has coverage, they must provide to their payer the expected billing and diagnostic codes, the claims that they expect that will be covered in that episode of care. And if that individual does not have insurance, the provider and facility would provide directly to the patient a good faith estimate of the amount that they may charge for that episode of care. Now, again, the implementation deadline and the statutory deadline, meaning the deadline that Congress originally put into place, was January 1st, 2022. But this provision has a direct interaction with Section 111. So going a little bit in reverse. Once that good faith estimate is either provided to the patient, or if they have coverage, is provided to the plan, the group health plan or the individual health insurer then has the opportunity, the obligation to turn around and provide what is called an advanced explanation of benefit to the patient 1 day after they get the good faith estimate from the provider or facility. That's a little confusing. So I want to put this into kind of a real world scenario. The way that it works right now is, let's say me, Buck, I go to the doctor and I schedule a physical, right? The doctor would put me on the calendar, I'd show up for my appointment. And when I get home, typically, a week or so after the episode of care, I would receive an explanation of benefits that shows the billing codes, the diagnostic codes, the claims, what was covered by my insurance plan, what was charged by the provider, and what was the allowed amount. And then at the end of it, what my out-of-pocket obligation would be. The intent, the congressional intent of this proposal is to move that to the forefront of the episode of care, to increase transparency and increase knowledge of the patient of what the expected care will be received. That requires direct interaction between providers and facilities and group health plans and individual insurance issuers to collaborate on the sharing of that information, right? So in short, once I go to the doctor in this new setting, once I go to the doctor would have to turn around, verify my insurance, provide my insurance with the expected billing codes. And then the insurance company would turn around and say, here's your advanced explanation of benefits. And these secondary bullets are what it must include. So it's your network status, it's the contracted rate, it's the good faith estimate, the plan responsibility, the cost sharing, out of pocket max. If there's a medical management limitation that like prior authorization, this is where that information would be provided. The obligation, there's also an obligation that there's a disclaimer that says this is only an estimate, right? And then the secretary could also provide a modification to this quick 3-day timeline for low utilization or significant variation in costs, right? So this is typically, perhaps it would be a high cost, low utilization, or a low utilization, high volume, low cost type of procedure. There could be some exceptions for the secretary. Now, again, I throw a lot at you there, but the good faith estimate and the interaction with advanced explanation of benefits must be provided for all episodes of care. This is separate and unique from the patient protection. It would be for all episodes of care, top to bottom across the health insurance industry. And the statutory effective date was January 1st, 2021. Keep in mind, that's the date that Congress put into place for this to take effect. The last transparency provision we're going to discuss before we get into timelines is a price comparison tool. And this is an obligation that group health plans and individual health insurance issuers must provide price comparison guidance either by phone or through a web tool for shoppable services. This is again designed to provide more transparency, more opportunity for a patient to make informed decision on where they would like to seek care based off of cost. And the statutory effective date, meaning the date that Congress put into place, once again, was January 1st, 2022. Now, there's a handful of overlapping regulations, 7 primarily, dating back to the Obama administration across the health insurance industry that are either duplicative or overlapping with the 10 legal requirements that Congress put into place. But primarily, we're going to focus on the payer obligation for machine readable files for negotiated rates, which this will make sense as soon as we jump forward. So the administration about 2 weeks ago came out and put forward a set of frequently asked questions to clarify the overlapping and duplicative regulations. So you see here are the 4 transparency items that we walked through, as well as the payer obligation for machine readable files. And what the administration said is, since these are overlapping and duplicative timelines, we're going to try to provide some clarity and some certainty to the industry so that they can get into a state of compliance without being squeezed on one end or the other into unrealistic expectations that they could meet all of these timelines by January 1st, 2022. They didn't explicitly say this, but reading into it, if you separate it once again from the patient protection and transparency, the patient protection is still set to go forward January 1st, 2022. And so it would appear that they're prioritizing the patient protection first and understanding the massive undertaking that patient protection is going to be across the industry, from providers to facilities to laboratories to diagnostic services to pathology. That gives breathing room on the other side for transparency to take effect. And so for the items we discussed, the cost sharing on the insurance card, the administration came in and said, we are going to provide an opportunity for good faith compliance beginning January 1st, 2022, until we provide future rulemaking. Good faith compliance does not mean that group health plans and individual health insurance issuers should not attempt to get into a state of compliance. It means just the opposite, that they should attempt to take a good faith effort to provide the cost sharing obligation, ways that you can reach out if you need consumer assistance on your insurance card. However, they just won't be enforcing it until there's future rulemaking. That's similar to the advanced explanation of benefits and good faith estimate. The only difference is the enforcement was deferred altogether for the AEOB and the good faith estimate. There's not a good faith expectation that industry will get into a state of compliance. And they said that for the AEOB, advanced explanation of benefits, the enforcement is deferred until future notice and comment rulemaking, which is different than just generic rulemaking. Notice and comment is the most formal process through the Administrative Procedures Act that the administrative branch, the executive branch, can execute implementation of laws. And that notice and comment rulemaking process is very structured. There would be a draft rule, that's the notice. There would be comment. After the comment period takes effect or closes, typically 180 days, they would come in with a final rule. Once that final rule is issued, there would be another on-ramp to get into a state of compliance. This can typically take roughly a year, sometimes much longer than a year. And the same is true for the good faith estimate, although they did not specifically say notice and comment rulemaking, they just said pending future rulemaking. But given the interaction between those two, it's fair to anticipate that there would be the rulemaking would come out at the same time. The fourth is the price comparison tool, and the enforcement is deferred to January 1st, 2023. The reason there is in the rule that the Trump administration issued for machine readable files, that transparency and coverage rule had an obligation that there was a price comparison tool. And since there was a statutory deadline of January 1st, 2022, and a regulatory deadline of January 1st, 2023 in the transparency and coverage rule, the administration took the latter of the two to give payers a longer on-ramp to get into a state of compliance with the price comparison tool. And then finally, the machine readable files. This is the Trump administration transparency and coverage machine readable file requirement on payers. They delayed the enforcement of that rule from January 1st, 2022 to July 1st, January 2022 for the in-network obligations and out-of-network charges. And they deferred the enforcement on prescription drug costs, which are both in-network negotiated rates and out-of-network historical net prices, pending notice and comment. So I'm gonna actually, can I go back a slide real quick, Andrew? I'm sorry to do this, but let's go to this slide. And I think this is a good, oops, apologies. Let's go there. I wasn't planning on driving, so you got to cut me a little bit of slack. So here's the timeline. Congress passed the No Surprises Act as part of the Consolidated Appropriations Act at the end of December 2022. That there were some provisions that took effect upon enactment, December 27th, 2020. But for the purposes of this discussion, the first interim final rule was issued July 1st, 2021. And that's an interim final rule, meaning the rule takes effect basically the same time it comes out. They did have some comments or request comments on a handful of provisions, and comments are actually due yesterday for the purposes of that interim final rule. Paid to be a second interim final rule, and that would address the patient protection, right? So that would address the independent dispute resolution, how the factors such as the quality of the care and the complexity of the case and the median and network rate, how those factor into the decision that the arbiter should make when they're selecting which party should be, basically what the payment should be based off of what was charged and what was covered by the insurer. And then there is a third expected rulemaking, which is a notice of proposed rulemaking. And that NPRM is expected to be September, October. That's dealing with the enforcement of the law. So taken together, those three, the part one of the interim final rule, which came out July 1st, part two dealing with the independent dispute resolution, which is expected, quite frankly, any day now, and then the notice of proposed rulemaking, the NPRM, that those three taken together will kind of put together the three different pieces of the pie on how the administration is going to implement both the patient protection and the transparency provisions. Now, looking at January 2022, it's fair to anticipate that the patient protection will take place. But given the frequently asked questions, it's now safe to assume that the administration has deferred enforcement on the bulk of the transparency provisions to allow oxygen, to allow room, to allow space for industry to get into a state of compliance with the patient protection itself. So, Andrew, I feel like that's a good place to perhaps stop. I don't know if there are questions in the queue or if there are a couple of questions that you want to ask.
Yeah, let's open it up and see if there's questions in the queue, and start there.
At the moment, there are not questions in the queue.
Okay, if there are any questions to start out with, go ahead and ask them. We have a few that I think we can run through that have come up to us that I think would be good. So Rory, why don't you go ahead and ask your first question?
Yeah, of course. Let me grab that real quick, unless Rachel has it.
Sure.
I see a question. I see a question here. How can pathologists give notice of services? So pathologists are exempt from giving notice and consent. They are one of the 7 specialists who are not allowed to provide notice and consent to balance bill.
We've got another, and just to be clear, does this legislation impact apply to care at in-network facilities only?
So just to be clear, Penny, appreciate the question. It's a very fair question. The scope of this legislation is emergency services and hospital-based settings for, so it would be an out-of-network facility with an in-network provider or an in-network facility with an out-of-network provider. More than happy to kind of walk through that again. So if you go to the emergency room, you don't seek, you don't select who your emergency care doctor is, typically, right? Also, if you're on a road trip with your family and you get into an accident and you're taken to an out-of-network facility at no fault of your own, you should not be held to an out-of-network cost sharing arrangement, an out-of-network obligation. So that's for the emergency services. For the hospital-based services, you can think of it as 2. One, it would be an out-of-network hospital with an in-network provider, or an in-network hospital with an out-of-network provider. More than happy to continue down that road if helpful.
Okay. We got a question from Gina. What about such as genetic testing done on pathology samples?
So for the specialists that are listed, it's really probably most helpful to read through a little bit of the regulation where they talk about what constitutes a visit. So I'm reading this verbatim through the rule. With respect to items and services furnished to an individual at a healthcare facility, this includes, in addition to items and services furnished by a provider or the facility, equipment and devices, telemedicine services, imaging services, laboratory services, and preoperative and postoperative services, regardless of whether the provider furnished such items or services at the facility. So what does this mean from a pathology perspective or a laboratory perspective? This would mean that if you are a patient and you are in one of these settings, for the purposes of this example, I would say you're at an in-network facility with an out-of-network provider. If that provider orders out-of-network samples, either laboratory or pathology samples, you are held, the patient is held harmless to their in-network obligation because they did not select that laboratory, they did not select that pathologist. And so they, at no fault of their own, should not be charged a higher rate.
Okay, we've got a question from C. Fravel saying, regarding the good faith estimate, how can pathologists give advance estimates to patients?
Yeah, so I'm looking, I think there's a couple of questions about this. I'm going to try to answer them all in one scenario. So a pathologist, so again, these are, it's kind of hard to explain. You have to think of it in 2 different, in separate and unique silos. One is dealing with the patient protection. The other is dealing with services that are scheduled care, right? So clearly a pathologist, it would be unique for somebody to schedule care with a pathologist, right? So if there was a setting where where me as a patient sought out care from a pathologist and I selected that pathologist and it was 3 days in advance, you have to check all these boxes, then you would provide a good faith estimate to the patient. If it's not, you don't have to, right? Most of the time, those pathology reports are going to be ordered by an ordering physician, and that practitioner, would do the referral out. So you have to check all these boxes in order. Scheduled care is the most important one. This is care that you were seeking out, you were scheduling in advance, and you were being provided with care that you sought out in advance. To go to Jeanette's question, I'm sorry, I'm jumping around. I'm looking at the questions as I go. That goes from the transparency provision back to the patient protection, which again, I know this is very hard. I've had to whiteboard this out for Andrew and their team before, because I have to like basically draw into silos when which are captured. So for the purposes of the notice and consent, that is only available for scheduled care, right? When I say that pathology is exempt, I mean that means that they are exempt from the opportunity to provide notice and consent. They cannot provide notice and consent for a patient to knowingly consent to out-of-network care. So let's put that into practical terms. Again, back to Fravel's question about advanced estimates for pathology. For the purposes of if I'm in a hospital setting and I receive care, they order labs, they order pathology while I'm in that setting, there's no obligation for you to get notice and consent, because you cannot, period, right? Neither can an assistant surgeon, neither can an anesthesiologist, because those items are being ordered by the ordering physician, right? So they are not allowed to, when I say exempt, perhaps I should say not exempt. I mean, I'm trying to think of it from a double negative perspective, Jeanette. Perhaps that's a better way of framing it. But the short of it is, since that's being ordered by someone else, that pathologist does not have the luxury of knowing the patient to go to them and to get their consent and then balance bill them. And if I'm still confusing you, I'm so sorry. Feel free to ask the question a different way.
Yeah, Buck, the way that I would think about this, about the good faith estimate in pathology, is if a patient is going to the hospital to get a biopsy, that's a scheduled service. They're going there to get the biopsy so the pathologist can read it. Are they, in that circumstance, subject to the good faith estimate and the advanced COB?
Yes, if in that scenario, if it is scheduled care and it is 3 days in advance, yes.
Yeah, and that's the way, at least, and anybody kind of out there, kind of tell me if I'm wrong. That's the way pathology, outside of I'm an in-network in the hospital setting where I have a biopsy, a lot of this is scheduled to go get the biopsy. And then I think the other one that deems in pathology is, if somebody is going to see their oncologist out of their practice and they're getting a bone marrow pulled in the office, that is then part of the good faith estimate that needs to be done.
Yeah. Now, the good faith estimate would be, Gina, in the scenario that Andrew's talking about, if the pathologist is in network, right? If they're out of network, well, no, two different settings again. It's two different settings, right? So one would be if it's scheduled care and they're out of network, they would provide them with that good faith estimate. They would say, we're out of network, but here's a list of people who are in network, right? That's one of the obligations, is that they must provide a good faith estimate as well as a list of providers that are available to provide that service. If there are no, let's use a hospital setting, okay? If there are no in-network pathologists, they're all held to the in-network obligation. In other words, if the patient does not have an option of an in-network, they cannot be they cannot be balance billed, right? Because they have no option to an in-network provider at all, period.
Yeah, and I think, Buck, the other one is this, I'm an OBGYN is in-network sending to an out-of-network lab that is a sole source provider of a test, meaning they're the only one with the test. How does this apply? The good
to a
faith
sole
estimate.
source, the good faith estimate of this.
Yeah, the good
honestly,
faith.
Andrew, I honestly don't know if I have a clear answer on that specific question. I know this is a source of ongoing discussion between the administration and pathologists and labs for the purposes of comments. And I would recommend that if folks have strongly held views of how that specific scenario and sole source providers should be addressed, that they weigh in with the administration through the comment and the rulemaking process.
Okay, good. Because a lot of those, I think, sole source tests are used on what I would call miscellaneous CPT codes. So it would be hard to apply in network. And I think that's where the question's driving from.
Correct. I'm trying to make sure I didn't miss any questions. Is Bonnie one that I did not address?
Oh, we've got another one from C. Fravel. Do you know when the insurance medium fee schedules will be established for what out-of-network providers can charge?
It's a very good question. So the way that this law works for the purposes of the patient protection, again, take the good faith estimate and the advanced explanation of benefits out. That's a question that focuses on the patient protection. The way that it works is insurance companies will use their own median in-network rate by geographical region, by service, and it's a historical rate. It's backdated to January 31st, 2019. The reason is there was concern in the provider community that there may be an effort to reduce or limit the size and the capacity of in network, basically your network adequacy, right? So it's backdated, and that rate is audited by the federal government on an annual basis. Now, the first part one of this interim final rule, which I just discussed, outlines how the geographical regions are designed, how the insurance markets are designed, how the items and services are designed, and all of that factors into how a plan produces that median in network rate. Median meaning middle, not average would be the mean. So that means 50% of providers that would be above it, and 50% of providers would be below it. And that's not going to be provided at a fee schedule on an annual basis. And it's not going to say that if you're an out-of-network provider, this is all you can charge. The median and network rate is used for two things. The first is calculating a patient's out-of-pocket obligation. Without a number, it's hard for you to know what you can charge the patient out of pocket. So that median and network is established so you can calculate the cost sharing obligation. The second is for if there's a fight between or a dispute between an out-of-network pathologist, for this example, as opposed to in the insurance plan, that median and network is a consideration for the arbiter to look at in determining whether they're going to take the charges that the provider billed or the amount that the insurance company is willing to pay. So that is what the purpose of the median and network rate is.
Gotcha. And I think Bonnie has asked this question a second time. So if a pathologist who doesn't balance bill, are payers required to pay you at their in-network rate?
Well, it would depend if you're in network or out of network. If you're in network for the patient who is in the episode of care, you would be paid your in-network rate. If you're out of network for the patient at question in the episode of care, the payer would provide you either an initial payment or they would send a denial, and then you would go to a dispute resolution over what the adequate amount of the coverage is.
Yeah, and so I think to Bonnie's question, your billing practices and how you may or may not balance bill, I don't think plays into this. It's really around network status. And whether you're in network or out of network. Okay, then the next one is I'm an independent lab and a physician sends me a specimen where I'm out of network for that patient's plan. Am I obligated under this legislation to provide an estimate to the patient and hold the patient harmless to balance bill?
Independent lab and a physician sends me a specimen where I'm out of network for the patient's plan. So if I'm going to put it into a hypothetical, if I go to the doctor, I have a procedure, and I'm at an out-of-network facility receiving care from an in-network surgeon. In the course of that episode of care, if that in-network physician orders a specimen from an out-of-network independent laboratory, the patient only pays the median in-network, the cost sharing based off of the median in-network. Since that is not a scheduled episode of care, you do not have to provide an estimate to the patient, but the patient is held harmless from your ability to balance bill in that setting. That's why, again, you have to think of this in silos. I think that everyone is asking very valid questions, but you have to think of those episodes of care unique and separate from scheduled care and out-of-network care at an in-network facility or in-network care at out-of-network facility. So think about it again. Patient protection, scheduled care for transparency. Transparency only applies for the scheduled care settings. And the patient protection for the median in-network rate cost sharing obligation only applies in those settings where it's an out-of-network facility or an in-network provider, or an in-network provider and an out-of-network facility. So again, to walk through that, I think it was Jeanette, if I'm a patient at an out-of-network facility with an in-network provider and they order a specimen to your out-of-network facility, you cannot balance bill the patient for the difference of what you charge and what the plan covers. You would go to an independent dispute resolution process to resolve the difference in that dispute. If you take that out of it and there's a scheduled care for a specimen and it's 3 days in advance, you would be obligated to provide a cost sharing. Sorry, a good faith estimate.
And Janet, I think one of the things that gets confusing here is the association with kind of in-net or inpatient, outpatient, non-patient, right? In the non-patient setting, transparency is there because as long as it's a scheduled visit. When you're talking a hospital visit, inpatient, outpatient, that's where this scheduled visit and holding the patient responsibility holds. So you've got to almost think about a patient going to the physician's office versus a patient going to the hospital, and they're treated differently. And that's the way that's the way the bill works.
So that's a great follow-up question she just asked. What if the specimen was taken to the physician's office? If it's taken to the physician's office, that is not covered by the scope of this law. You could balance bill.
Right, but it's covered by transparency if it's scheduled 3 days in advance.
That's true. You would have to provide the estimate, but you could also balance bill.
Yep.
I see another question. Are the median in-network fees published? The answer is no, because it's by plan, by geographical region, by items and services, and that's proprietary information. So to use an example, if Caremark were to start publishing their median in-network rates, that's proprietary and could have an impact on, their competitors. Now, there is again, separate and unique from this, there's the machine readable file obligation that plans do start to publish their in-network rates by items and services. That's a Trump administration era rule. This is already in effect for hospitals. They're obligated to provide their machine readable files for their in-network agreements. That was delayed from January 1st, 2022 to July 1st, 2022. So while they're not required to publish their median and network rates for the purposes of this law, there is a separate and unique regulation that's going to require insurance companies to publish their rates.
Speaking of delays, I know that we get a common question, which is, what is the likelihood that the enforcement will be delayed indefinitely?
So I'd say it's highly unlikely, because each of these provisions, let me just say it this way. Politics is a game of addition, not subtraction. And each one of these provisions carried votes. So for example, the advanced explanation of benefits was the top priority of the ranking member of the Ways and Means Committee, Kevin Brady of Texas. And since he fought very hard for this provision, he's going to lean on the Biden administration very heavily to implement this. Another good example would be the continuity of care and the good faith estimates. This is something that Democratic lawmakers in the House fought very heavily for. And the Biden administration, understanding they're going to need the votes of Democratic lawmakers for other healthcare priorities, is likely to carry out their priorities and then under like kind of a mutual understanding that they'll help Biden carry out his priorities as well. So I think it's highly unlikely that there's an indefinite delay. I do think that there is an acknowledgement and an understanding of the confusion, which quite frankly is very evident in some of the Q&A that we're discussing right now. It's hard to explain where this protection begins and ends, where the transparency begins and ends. And so the administration is trying to provide a little bit more of an on-ramp to allow some flexibility. So that is why you're seeing an initial delay. I don't anticipate, Rory, that there would ever be a permanent delay.
Okay, this has triggered a couple more questions now. This is from C. Fravel. Labs don't know if a doctor has scheduled a procedure, so how can they follow the 3-day advanced good faith estimate? If the medium fees aren't published, how can a lab pathology know what the patient can be billed? Which I think kind of goes into another one of our frequently asked questions. Since there's no direct technology to facilitate getting a good faith estimate between facilities and physician offices in the health plan, how is that ever going to become a reality?
So there's a difference in what a lab would bill, and then I think we all get this, right? Like there's billed charges and then there's allowed amounts, right? two completely separate and unique things. The cost sharing obligation, if let's say it's a percentage of the billed charges or a percentage of the allowed amount, or there's an out of network obligation that it's like 110% of the billed charge, or I'm sorry, 80% of the billed charges. That is where there is a requirement that there's direct interaction between providers and facilities and insurance plans and issuers. I mean, I think to zoom out, one very easy way to think about this is today in the healthcare system, there is a necessary continuity and a necessary communication between the payer and the provider, right? I think we can all agree there's not always a seamless communication. There's not always a streamlined continuity. And the entire intent of this law is to say, do that better, right? That's as blunt and as candid as I can be, is we understand that there are sometimes confusion. We understand that in order for you to figure out what you're going to get paid from the patient and what you can get paid from the provider, from the plan. However, the innocent victim of that conflict has become the patient, right? And now that the patient can no longer be used as the innocent victim to encourage the plan to pay a higher reimbursement, encourage the provider to pay a higher reimbursement, because neither one of them want to be viewed as the boogeyman. The two sides have to figure it out. And I know that doesn't make people happy. Trust me, I lived it for the last 2 years. This was the most lobbied issue in Congress for 2 consecutive years. There was $50 million spent on this law to kill it, right? So the point is, there already is a requirement that you engage and interact with your counterpart. If you're the provider, that means the payer. If you're the payer, that means the provider. What Congress is trying to do is say, speed up that cooperation and take the patient out of the middle so they can no longer be used as a chit to either increase your reimbursement or, increase the allowed amounts from an in-network perspective, right? So that's a long way of saying it's not really necessary for you to know what the median in-network is for the purposes of like going to a physician's office, because for starters, the patient protection doesn't extend there, right? The median in-network rate is relevant when it gets to the point of deciding what the payment resolution is going to be based between your billed charges and the amount that the insurance company pays you, right? So again, let's use a setting. If I go to an out-of-network facility or an in-network facility and I get an out-of-network surgeon, that out-of-network surgeon may choose to bill me, I'm just going to use simple math, $500. Since they're out of network, historically, they could charge $500. The insurer may come in and say, I'm actually only going to cover 100 of it. And then the provider would turn around and charge the patient the difference, that $400, that's your balance billing. Since you can no longer do that, for the purposes of determining what is a fair and an equitable and a reasonable amount, the median network is utilized for 2 purposes: the cost sharing obligation and to help come to some resolution on the payment. So it's not always necessary for you to know what the median network is. And quite frankly, you would know what your median and network reimbursement is by plan. Let's say, it's Care First, you would know that historically your median network reimbursement for them for that same $500 service has actually been $250.
Yeah. So I think one of the questions here that I'm seeing is, laboratories typically do not know when a physician's going to order a test. So a physician can schedule something 3 days in advance, and as part of that, they're doing a blood test, and they know that. But the laboratory is unaware that physician is going to draw and send to them on that given day, right? The physician's not telling the laboratory they have a scheduled visit and that the patient. So in that circumstance, who has to provide the good faith estimate? The provider, meaning the physician in the office, or the laboratory? Yeah.
So if it is again scheduled care in a physician's office, it would come from that physician, right? It would have to be that physician you would schedule the care. The physician would double check with your insurance company what your network status is. The insurance company would provide confirming information, and then the insurance company would send it back to the provider, and then the patient receives an advanced explanation of benefits, right? Like it's kind of like a snake. It goes down and then it comes right back, right? So that's why there's this weird exception, not a weird exception, this unique exception, I should say, for advanced diagnostic laboratories. Those are scenarios where you may go directly to the advanced diagnostic laboratory and schedule that type of care, right? In most other settings, it's from an ordering physician, and that would be included in the episode of care, the codes and the bill charges that or the billed claims that they expect to provide during that episode of care.
Yeah, and so another question around that: will the lab have to provide the information to the physician, like the tests, fee schedules for insurance plans, or will the physician have to contact the lab each time to figure out the cost? The thought process there is, if the physician's sending it to the insurance company should have all of that information.
That's right. They should already have it.
Yeah, so I don't think it's the lab's responsibility to do any of that at this point. And then another question, it may come from a hospital laboratory. Oh, so there's this question of reference laboratory, right? So
correct.
One lab sending to another lab, and how does that work?
Right. So I mean, it would ultimately be with the provider who is listed, right? Who is, whose name is there and who is the person who performed the services, and those items or services would go up to the physician and to the patient. And then will there be a notice that the patient has been provided with advance notice and their payer is allowed to share that information? Will there be a notice? I'm not sure I'm tracking. Will there be a notice that the patient has been provided? With like the advanced explanation of benefits?
Yeah.
Yes.
Yeah, and I think the question is, so the physician schedules the service, they run the advanced DOB. Will there be any information shared back to the laboratory that was
that they were? Yeah, correct. Yes.
Okay, so there will be. Okay, we have time for one more question. We're getting ready to wrap up. Is there anything else that's burning out there that people have questions?
Andrew, I'd also say, I know that a lot of this can be very convoluted and very twisted and very confusing. And that's one of the reasons that we wanted to host this call today, is to help provide some clarity. And I do anticipate that there will be continued discussions as you go back and collaborate with your colleagues internally. And I'd be more than happy to, one, be a resource. We can throw up my information on the screen and I can actually type my email in right here.
We can go to the other resources or the last page, and we have, Buck, your email on the back on the presentation.
We will provide this deck to you. Here's a handful of other resources. I am more than happy to be a resource from a one-off perspective. If people want to send me follow-up questions, I can help steer you to the right resource. But just in general, we'll provide you this deck. Here's a couple of resources, and I'm more than happy to point you to some frequently asked questions that not only the administration has put out, but also that some academic folks and non-biased, non-industry folks have put out as well. But just a couple key takeaways before we wrap up. We've got about a minute left. This is essentially what we wanted you to walk away with, that for the purposes of the protected episodes of care where the patient is held harmless to their out-of-pocket obligations, laboratories are facilities when it is included in that episode of care. If you're an out-of-network provider at an in-network facility and the labs and pathology reports are ordered, you are obligated by this law. Facilities must provide a good faith estimate for scheduled care, right? Keep in mind, this is for scheduled care. And that enforcement is currently deferred until there is additional rulemaking. And then the statutory effective date for the patient protection is January 1st, 2021. And the statutory effective date is January 1st for the good faith estimate, but that enforcement is expected to be deferred. The penalty for facilities is set at $10,000 per violation. This is consistent with other civil monetary penalties, but just so you have some awareness of what that anticipated penalty is going to be set at, it's up to $10,000 per violation. So in short, kind of to wrap up, we wanted you to have an awareness of not only the patient protection, but the transparency components of this legislation. And I'm more than happy to be a resource moving forward and providing answers to questions as folks have them. So I really appreciate the opportunity to be here. And Andrew, I'll just kick it back to you.
Yeah, thanks, Buck. And we're glad we could put this on and bring Buck out here to really explain what's going on. Our plan is to do, as we get more information and learn more, is to do another one of these to really flush out questions. As Buck is a resource, we are also a resource to you guys. So we've learned and spent time with the bill. So happy to kind of help out where is needed from a resource perspective. And we thank everybody for jumping on. Please reach out to us or to Buck if you have any other questions, and look for some ongoing webinars around this legislation. So we want to thank everybody for the time that they spent, and thanks to Buck for spending the time also.